I think we should, kind of put a bite size little, I guess, mini clinic, mini med school, mini residency thing together for anyone who listens to this. And, maybe the chief residents or whoever's inspired to be a leader like you were in residency, they can, take it to their program and present it for noon conference. So I wrote down the notes here, the three content areas. So we'll just go through them, I guess, and take turns. The first you said is, what is palliative care and hospice? We need to
Mhm.
define it so they know, right?
Yep, absolutely. I think like how are they similar? How are they different? And one big point that we emphasized in our training was when you use those words, making sure that you and the patient are talking about the same thing. So very recently, I
Mm,
had a patient who I mentioned hospice, and she was like, "Well, no, 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 I don't want to go to hospice," and really
mm.
realizing that you have to get on the same page, have the same definitions, and understand where your patient's coming from. And you can only do that if you understand those things yourself. And I learned a lot from the training, having thought, I had some expertise already, right? And then I go into the training and I'm like, wow, I actually learned so much from this. So that was the first key area that we focused on that I think is huge for incoming trainees.
Wow. And then the structure of a goals of care conversation. What are goals of care?
Yeah, so we focused a lot on defining that, right, exactly like you said, and sitting down with the patient and having the skills to pull out what are the patient's goals from the conversation. So really using different tools like nurse statements, like wish worry statements, all those kinds of things to get from the patient what is most important to them in whatever time that they may have related to their chronic illness, and what is quality to them, right? Like, what is a quality life? What is a quality time period? Um, and trying to see if there's any particular goals, events, things that are really important to them that they want to get to, or milestones that are really important to them, and arranging their care around those things and making decisions with them around those goals.
Yeah, hearing you say that, makes me think about some people, every culture is different, some cultures, they're taboo about talking about death, like you
Mm-hmm.
really cannot mention that. Some, cultures, they don't want to feel like they're missing out on anything. I can speak for, Black Americans, not everyone, but there is a historical distrust with the healthcare system. So they
Mm-hmm.
may not want to think something's being taken away or withheld if there's already
Exactly.
distrust. So it boils down to what disease process are we dealing with, right? Go back to the
Mm-hmm.
COPD we just mentioned or the heart failure. We know what it's doing. And I think it goes back to the education.
Yeah.
You got the diagnosis. How long does it typically go? Alzheimer's is another one. When I get the patients, I'll ask, did a neurologist tell you like how this is going to go? And some people will say no. And I don't know if that's true. I'm not picking
Yeah.
on anyone here,
For sure.
but it's like they didn't know that
Right.
this was going to lead to being bedbound, incontinent, not talking, not eating, and all
Mm-hmm.
the things that we see when we're at the hospice stage. And so, it's just having those conversations early, which your
Yep.
curriculum's doing. And then so they're not surprised or feel like, they're being abandoned by the healthcare system because I know some people, when they get there, they're like, a daughter, they just want their mom to get some IV fluids or get that UTI treated.
Right.
They have a stage 4 sacral ulcer. And it's like, no one's talking to them. It's
Right. Right.
talking.
Right.
Conversate. We need to be conversation champions.
Absolutely. And
Um,
exactly like you said, too, assessing how the patients and families like their information delivered, right? Some people, it's small chunks. Some people, they, might have a different strategy where they want all the information up front and then digest and ask more questions later. So to be able to ask the patient how they like their information delivered and also sense that is a whole nother topic in and of itself, but very important as well.
Yeah. Well, then the third part of our content that you can teach, they can do this the first 3 weeks of residency. How to identify the legal decision maker. And there's synonyms with that. Some places
Mhm.
call it a surrogate decision maker, a healthcare proxy, what is it, a DPOA, all these
Mhm.
words. Just be simple. If you cannot make decisions, who do you trust to make those decisions for you?
Mhm.
Right?
Absolutely. And one of the things that I found so confusing is the state where I went to medical school and then the state where I trained in residency had inverse definitions of what surrogate was and what proxy was, meaning one term meant the person you appointed, and then the other term meant the person that it falls to by law if no one's been appointed. And I was like, well, how do I figure this out? These terms are all so confusing. So, for our listeners, I would say if you're at all confused about what the laws are in your state or what certain terms mean, you can certainly reach out to your social workers. They're excellent resources. Rely on the interdisciplinary team to point you in the right direction to help educate you about the laws in your state. And then you can always look up those laws. So for me, I trained in Florida for my residency. They have a very clear healthcare proxy law and who it falls to by law if there's no designated person that the patient has said, this is the person I want. So just a little tidbit for everybody out there, rely on your interdisciplinary team members because they can be super helpful in these areas as well.
Yeah, and if you're not in the hospital or on palliative or any of that,
Mm-hmm.
the NHPCO, the National Hospice and Palliative Care Organization, has a beautiful website called Caring Info. I'll put that in the show notes, and you can look up those things too, and they have state
Mm-hmm.
specific information.
Beautiful.
I think that's great. So I wish everyone the best in residency, intern year, the transitional year, and all the things people are doing. Do you have any advice
Mm-hmm.
since you were a successful chief resident?
Advice, I would say embrace every opportunity you have with every patient and every mentor and learn. Soak up the knowledge. That's what I found, especially in intern year, ask the questions. If you're not sure what a term is, I messed up the proxy term, right? Ask. That's the most important thing you can do in the beginning. And then as you progress through your training for the chief residents, be advocates. If something doesn't, if there is a certain area that you feel like your residents need to learn more about, you are the advocate to bring those resources in to bestow that on the trainees at your program. So empower yourself to do that. Those are my two words of
Yeah,
advice.
thank you. It's such a privilege, to have that, and I wish you the best in your fellowship. I hope your whole fellowship team gets to go to the annual assembly next year, and we'll have some more fun.
Yes, I'll be there. I'll see you there.
All right. Thanks for joining me today.
Thank you.